You're listening to the Move to Value podcast, powered by Chess Health Solutions. The Move to Value podcast is dedicated to helping healthcare providers understand and make the transition into value-based care. We do this through conversations and the sharing of innovative ideas with practitioners, experts, and leaders throughout the healthcare industry. Our mission is to sustainably transform the healthcare experience for the patient, provider, and care team by cultivating a value-oriented, compassionate, and health-aligned community. In this episode, we hear more from NCAHEC's Chris Weathington about the inevitable integration of behavioral health and primary care and the need to realign incentives and alleviate some regulatory burdens so practices can find service enhancement opportunities to remain viable and more accessible to the patients they serve.
Promised you we would get back to the behavioral health, and so I want to dig in a little bit there. As you know, the North Carolina was chosen as one of the states to participate in making care primary. I know your team has done a lot of work in helping practices get information and making that determination whether that is right for them. Behavioral health integration is a critical part of that program. And you mentioned the collaborative care model that you all do and to support. Can you talk a little bit more, not only about your collaborative care model, but also if you are seeing or envisioning that there'll be more integration of behavioral health, either because of making care primary, or do you feel maybe it's that may confuse it and maybe it slows down behavioral health integration? What are you seeing?
Well, great question. Just one more thing. You asked an earlier question, what practice managers potentially could be proud of. I think with this day and age is everything to be successful is not an individual that is accountable for success. It's truly a team. So practice managers who are able to not only recruit but retain a family of high-performing team members. I always appreciate practices that have kept their staff for many, many years. And I know that's very difficult this day and age, but those that are able to do it seem to be the ones that are most successful in keeping the doors open and delivering high quality care. But as you talk about behavioral health, that is something I'm very passionate about. I myself do not have a behavioral health background, but I am drinking the Kool-Aid, if you will. And it's because a few years ago, the North Carolina Department of Health and Human Services, Medicaid, came to AHEC and said, hey, we would like to see what we can do to encourage or foster primary care to adopt behavioral health. Because as we all know, when a primary care provider sees someone with a behavioral health need or condition, they often have to refer out. And referring out is very, very hard these days with the limited workforce to take care of folks with depression or anxiety or some other behavioral health need. So what we did is we developed a training curriculum of courses and also offer learning collaboratives for practices that are interested in implementing the collaborative care model and also implementing best practices. So we have a course catered towards individual components of the work. And the collaborative care model is pretty simple. It is basically a PCP, a primary care provider, working in conjunction with a behavioral health care manager and a psychiatric consultant to screen and intervene for patients with mild to moderate depression, anxiety, and also pediatric ADHD. And there's some other behavioral health conditions that you can add to that mix, but that's pretty much the foundation of the model or those diagnoses. But one cannot truly close the quality of care gaps that are present with transitions of care or diabetes or hypertension or some other chronic disease when you're not really treating the patient holistically, both mind and body. And we tend to detach what is going on in the mind with what's going on below the neck. And so the collaborative care model really helps address that. So we've seen a lot of pediatric practices embrace this model, and COVID really pushed it where this need has been more recognized. Maybe it's partly because of the social isolation we've had during COVID. Part of it is probably, I think, it's just people are more accepting to get help where needed. And so North Carolina Medicaid and all of the commercial payers and Medicare have come to the table to pay for this. And they pay using a fee-for-service model, but where they pay based on time-based codes that are submitted once a month. And Medicaid pays 120% of the 2022 Medicare fee-for-service rates. And even if all your patients are completely Medicaid or Medicare, you actually can cover your cost where a behavioral health care manager who takes on around 75 patients in a panel can fully cover your cost. Soon, we're getting ready to announce capacity building funds that are going to come from North Carolina Medicaid in partnership with Community Care of North Carolina, offering capacity building funds for more practices to ramp up this new model. The psychiatric consulting has been a pretty interesting situation where we have folks, psychiatrists in private practice or who work for health systems that are part of the North Carolina Psychiatry Association, and also NCPAL, which is a pediatric psychiatric service, that are willing to contract with practices to provide that psychiatric consulting. The care can be delivered on-site or virtual, and so there's a lot of flexibility with the model, but AHEC is here to support practices that are interested in doing this, and we anticipate that interest and adoption is only going to increase with time. When I was a practice manager, we really didn't do anything like this. The only time you would really see behavioral health integrated is if you went to a federally qualified health center. But now you're seeing private practices adopt it. You're seeing some behavioral health providers now working with primary care more. A lot of licensed clinical social workers are coming to the foray into this space. And so we're pretty excited about it, and I think it has a lot of potential, not only for holistic care, but one-stop shopping. So when you do go see a primary care provider, you can have all your needs met instead of being referred out.
That's great. I recall my practice management days, just as you said, there was very little, if anything, that was done in terms of integration here. A lot of times because of the sensitive nature of the notes and what is discussed in those visits, and it made it extremely challenging. It almost felt intentionally separate and sort of isolated. So what would you say to a practice manager or a physician practice who is concerned about one of the things we talked about earlier, which is just adding more administrative burden or challenges, but maybe interested in the collaborative care model, and what would their next step be if they were interested?
It's a fair question. Anytime you're starting a new service, that does take a lot of effort. All I can say is that AHEC is here to provide free resources, both in terms of training and technical assistance to help practices figure out how to do this work. We've seen a number do it that are small offices and some very large offices. But what I could say is think about, to me, it's a good investment because it will save time on the back end. When your referral coordinator cannot find a psychiatrist to see that child or that adult for things that should be easily managed, that's a problem for the practice. When you see patients constantly readmitted to the hospital or coming into the emergency room because their depression or anxiety has gotten so significant that it's impacted not only their behavioral health, but also their physical health, then that's a problem. And then so you have all these burdens that materialize on the back end, where if you just implemented the service on the front end, it would do wonders. And I think also just for a competitive advantage, you see a lot of health systems now embracing the collaborative care model or some form of behavioral health integration. And if the independent practices are going to keep up with that need in the community, they're going to have to offer something like this. So that would be the only thing I would suggest. I talked to a practice manager a few months ago who said, I'm a little concerned about this. I'm not sure whether it's worth the effort and time. But then she was talking about her son in high school and how he was super stressed and a little bit depressed about all the exams he was having to take and all the college applications that he was having to fill out. And she was really concerned for his mental health. And I said, if you had the collaborative care in your office, you could probably do something about that. And so she's like, oh, okay. So I think I understand some of the burden, but at AHEC, we're here to help you with the burden. One of the things we've offered also to practices, if they just want to have a discussion and figure out if this is a sustainable model for them, we'll sit down with them and help them with the pro forma and figure that out. And then as they go through the journey of hiring someone to be a behavioral health care manager or contracting with a psychiatry consultant, we're here to help them figure out how to solve those needs. And also, once they get those people on board, how to make sure they're all focused in a way that makes them most successful with the model. Because we don't really have to reinvent the wheel every time with each individual practice. We know what works, and we recognize some practices have differences. But if you largely follow the template, you should be able to be successful. And I would say finally, one of the admin burdens also often is provider recruitment and retention. And there are a lot of providers coming out of residency these days. It used to be, well, everybody had to have a high-performing EHR, which is still true. Well, a lot of residents coming out and say, well, when I was a resident, there were behavioral health providers at my fingertips. Well, if you offer that into practice, I think the residents or the new docs that are coming out say, well, great, then I can focus more on A, B, and C and know that I can refer down the hall to someone who can help them with their depression and anxiety. If you ask primary care providers these days, they will tell you a significant portion of their time is just filled in a 10 by 10 room dealing only with behavioral health problems. And when they have that resource under their roof, it makes a big difference and it makes them happier. And I think it helps reduce provider burnout. And I think it makes for a happier staff knowing that they can take better care of their patients. So,
absolutely. I can hear the passion there, Chris, and the importance. And
I told you, I'm drinking the Kool-Aid.
You are, and you got me drinking it too. I think I also am a firm believer in this, and it certainly can hear it in the way you talk about it and the importance of it. And I love the example that you gave of sort of making a real life connection there for that practice manager. That's great. Yeah, well, always a good way to convince them to do something is show them the real impact in their lives. So, sorry, go ahead.
Well, Josh, one thing is it doesn't have to be hard if someone doesn't want to take the time to recruit someone into these roles, and we do have resources for that. There's also turnkey virtual models out there, some very good companies that have been doing this for a little while and are very good. And so a turnkey model may be what is best for a practice if they're not quite comfortable that they can be successful recruiting and retaining someone. They can certainly go with that model, and we're happy to help facilitate that as a potential solution as well. So there's different ways to do this work for those that maybe, no, I'm going to go the traditional way and hire somebody, or I just want to work with a vendor who will help me do this. And certainly we learned from COVID that a lot of behavioral health can be delivered virtually. In fact, there often patients will prefer it for various reasons. And that is also something that's available on the table as well.
Absolutely. And I'll plug in that it's one of the things that CHESS can also help with as well. Services we can help practices that are interested as well. So Chris, looking forward, what do you see as the biggest challenges or changes for private practices in, let's say, the next 5 years in North Carolina?
Well, it's a good question. I'm sure I'm not telling you anything you don't know or that your audience doesn't know, but I'll just reaffirm or preach to the choir. I would say the declining reimbursement across all payers makes it very hard to stay open and provide services while your costs continue to increase, especially in the labor market. Part of that is inflation, but that seems to be a little bit higher these days than it used to be, but it's always been the case. And I would say, in addition to that, operating in both the fee-for-service and a value-based environment can be very challenging. I think 3 is recruiting and retaining your workforce. So what I would just encourage folks in leadership roles and practices, not to say that I'm perfect either, but I would say think very hard about being creative and being responsive to the needs of your staff. It's not always the money. It's having, there are other things you can do to make sure your staff are happy and high performing. And I would say a lot of the regulation and red tape, there's still a lot of that out there. I think at times either government or even private health plans make things unnecessarily complicated. So I would just encourage anyone who's in a regulatory or in a who works for a vendor or whatever you're doing, if the physician practice is your customer, spend a day or a week working in a physician practice. Just watch how they do their work, and you really can appreciate what folks have to go through to get the work done and to take good care of their patients. So I would say the admin burden only feels like it only continues to increase, and maybe there's a way to leverage technology to improve that or reduce that burden. But it sure is hard with reimbursement declining. And I don't know what the magic answer is for that. There has been discussion from providers about, should we go away from a fee-for-service model to a capitated model? There's some beauty in that with simplicity, but the reality is you're on a budget, and your capitated amount needs to keep pace with the rate of inflation. So I don't know if there's any perfect model out there, but you certainly need enough revenue to cover your expenses. And also look at your expenses and see are there things you're spending money on that maybe you shouldn't be. I know that gets harder and harder every year because practice managers, if they're doing their due diligence, have really found ways to be creative, but at some point you hit a plateau in what you can reasonably do. And I would look for service enhancement opportunities where it makes sense, staying on top of things, making sure you're offering at least what your a peer practice is offering it for your specialty down the road. Make sure you're doing that and giving your patients what they want and what they deserve. So, Josh, you may have other ideas of what folks should be doing or what they're going to encounter over the next 5 years.
Yeah. I was, as you were going through those, I was thinking, man, these could almost all be things from my practice management days that I would say.
Still true today.
10, 12, yeah, still true today that still continue to be issues. And as much as we've made progress in moving towards value-based care, those incentives to really make a full change and transformation to that is not only scary, but we're not quite there yet to fully have both feet in the water with it. So I think you hit on all the things that probably practices are feeling, and I'll throw a plug out there for you all that, as we've been talking about, the work that you guys do. They don't have to do this alone. They have support from you and your team, and you guys are amazing at it. So I would certainly encourage anyone listening that if they're having any issues with any of these challenges, to reach out to Chris and his team. And
appreciate that.
Of course, yeah, you guys do. Appreciate you guys and all you do. So, Chris, one last question that we'd like to ask all of our guests on the Move to Value podcast is, what's an important question that maybe I didn't ask today? So this is your opportunity to plug anything or talk about anything else you're passionate about, more behavioral health or anything else. What else would you like the audience to know?
What I think you've asked all the questions that I can think of. I guess what I would ask of you and I together is what can we do to help practices? Are there things that we haven't thought of that can make their lives easier? And I don't know what the answer is to that other than what we talked about today. But if folks could rewrite how primary care is delivered in a practice setting, how would they build it from the ground up if they had to do it all again from scratch? And maybe there's some things that we've been so much into the box all this time that we haven't had the luxury of looking from outside in versus inside out. Maybe there's some things that we haven't thought of that we could be doing. And I would encourage practice managers, physician owners, and leaders to speak up for what they think could work if they just had some cooperation and help from the ACOCIN, AHEC, Medicaid, CMS. You're never going to get something unless you ask. So that would be the only thing. And I know that's sort of a generic question, but to me, it's sometimes when you have these conversations, we spend a lot of time talking about things we know, but maybe there's something we just haven't thought of that could strike a chord and help someone. So that would be the only thing I would say.
Chris, I think that's a great response, and something that I would also echo, that as much as experience that I may have had in practice management with physicians and the work that I've done over the years, and you have done and your team have done, the reality is it's the physicians, it's the staff, it's the nurses that are working in these practices that are really going to have the best ideas and they're going to know better than us how and what will work for their communities. And what works in Charlotte may not work in the eastern part of the state or up in the beautiful mountains of North Carolina. So we also encourage folks to communicate what is it that you're seeing, what is it that we can help you do to make things better. And sometimes that's just an incremental step by step. It's not a change overnight, as we talked about, but I think that's a great way to end the segment. So Chris Weathington, thank you for joining us on the Move to Value podcast.
Well, thank you, Josh. Appreciate all the work you all are doing.
This is the Move to Value podcast, powered by Chess Health Solutions. We hope you have enjoyed this episode. If you would like more information about this and other episodes, you can head over to movetovaluepodcast.com to check out all of the available resources. If you're interested in continuing to hear about value-based care and how it impacts you, you can sign up for our email notifications or subscribe to this podcast on your favorite podcasting platform. Also, we would love it if you would share the Move to Value podcast across your networks and leave a rating or review. Thanks for listening.